Dear ladies and gentlemen, my name is Björn Bachmann. I'm giving this seminar now, and I want first thank the organizers of this seminar, Hunter, Lawrence, and Andy, for inviting me. And I think this is a very nice opportunity to present you my current approach in the application of modern imaging with our current treatment options we have in modern corneal treatments for different corneal diseases. So my focus in this presentation will be on modern imaging. And first, to give you some impression from the area from which I'm talking to you. So I live in Cologne. There's our university eye department, and Cologne is very close to the border, the western border of Germany, and we have some other countries around us, like the Netherlands, Belgium, Luxembourg, and also France. And we have quite a huge church in our town, which is the Dome Church. So many people coming from here are very proud of this Dome Church because it's a very old building. And the people living here are also very proud of having Carnival. And just this week, the Carnival season started, and they will have Carnival parties and also meetings every other day for the next 3 to 4 months. So this is quite a heavy time now for us to be here, because people are running around in the town like this. And this is our University High Hospital. This is a building from which I'm currently speaking to you. And we are 4 consultants giving the cornea service in our eye hospital. We have not only cornea, of course, we have all other ocular services we provide to our patients. But we have also a very special interest in corneal diseases, especially in lamellar corneal transplantation techniques. We perform 900 keratoplasties a year, of which about 600 are performed as DMEX or triple DMEX, performed by 3 surgeons. We have our own eye bank. We have different types of lasers. We have our imaging facility. We have a special interest also in ocular surface reconstruction, in corneal prosthesis, and also in keratoconus, and then many more diseases in the cornea and around the cornea. And we think the cornea is very interesting because of its very unique properties. It's a clear organ which is very unique in the human body. It has a very well-defined thickness of 550 micrometers, and there's not much difference in between different people or persons, though there's only variance of 500 to 600 micrometers, which covers most of the patients worldwide in thickness of the cornea. The mean refractive power is also quite well defined, around 43 diopters. It's clear, it's free of blood and lymphatic vessels, and it has a certain shape. It's prolate. It has an asphericity, which is important to overcome the spherical aberration, which is a physical phenomenon. And so this is very unique properties the cornea offers, and therefore we think it's a very interesting organ from the eye. And if we look at the imaging techniques which are available for the cornea, when it started with the cornea, one of the first imaging techniques was the video keratography based on Placido images. So this was the first transfer of images into the computer and calculations in the computer, allowing us to have a good overview, a map of the keratometry of the cornea. Also, this is helpful for diagnosing the corneal astigmatism, the regularity of the astigmatism, and it's also very helpful in diagnosing ectatic diseases, especially if the diseases start and are not so pronounced that you can already make the diagnosis by the slit lamp. So keratoconus indices came out with the video keratography some decades ago already. And most of the indices aim on the description of the irregularity of the astigmatism. So we see this bow tie, and we see that there is the difference in astigmatism when comparing the upper hemisphere with the lower hemisphere. And most of these indices try to calculate and to quantify changes in this specific shape of the astigmatism in keratoconus. And then there are also composite indices, and of these composite indices, for example, the Kieser percentage index is quite well known index from this surface topography, and it's based on the high level of the astigmatism, the difference in the inferior and the superior keratometry, and the skewing of the hemimeridians of the astigmatism. And taking all this together, this is already quite a good parameter to diagnose keratoconus at an earlier stage. But now we have the modern imaging techniques, which not only allow us to demonstrate the changes in the surface, at the surface of the cornea, but also have a three-dimensional model of the cornea. It all started with the optical Scheinflug or slit lamp beam or slip beam based pictures taken as tomographical pictures from the cornea, and they were able to, the stacks of these pictures can be used to reconstruct the three-dimensional model of the cornea. Almost at the same time, there came out the OCT imaging technique also for the cornea. And the first two generations, and they only aimed for morphological sections of the cornea, but the accuracy was not high enough to generate three-dimensional models of these sections. But now we have the third generation where we not only have the morphology, but also we are able to have three-dimensional models of the cornea, allowing us to have almost the same information we can achieve by the optical tomography techniques for the cornea. And then at the end of my presentation, I will also give some information on confocal microscopy in the context of cornea, which allows us to have a morphological display of the cornea at the cellular level. So starting with tomography, it can be either slit scan based pictures, or it can be Scheinflug based pictures. The first generation or the first machines were slit scan systems in combination with Placido pictures. These were the first tomography systems which had quite long measurement time and only had poor reproducibility. And then the next generation Scheinflug based techniques, which are based on rotating Scheinflug cameras, which take the optical sections through the cornea. They are much faster and have better reproducibility. And this is the standard of corneal tomography, or this has been the standard of corneal tomography for quite a while. It allows us to construct three-dimensional keratoconus indices. It takes into account the posterior elevation, which we know is an early or indicator for keratoconus in many patients, not in all, but in many patients. And it allows us also to have an overview about the spatial distribution of the corneal thickness. So we can use these informations to diagnose the keratoconus, but also to monitor the keratoconus to recognize the progression of keratoconus. These tomographical three-dimensional models are also very helpful to get an overview about the refractive corneal properties. It can display the asphericity of the cornea, and it also allows us to calculate the total keratometry of the cornea, which is very helpful when counseling refractive patients for corneal refractive surgery or also for lens surgery. And these techniques also allow us to get the backscatter image of the cornea, which is termed then the corneal densitometry. And I will also give some examples at the end where this might be helpful in modern corneal surgery. So this is a simple example of an elevation map, and elevation can be displayed by referring the shape of the cornea, either the anterior surface or the posterior surface, to a reference shape. And the reference shape is a sphere, which is called the best fit sphere. It's individually calculated for each cornea. And it's calculated in a way that the part of the cornea, which is here demonstrated by this red line, there are parts of the cornea in front of this reference shape. So you can calculate the distance from the reference shape in micrometers, and parts of the cornea are behind this shape, typically in the periphery. And you can see here the map where you can see the distances from this reference shape. And the sum of all these numbers should result in 0. So this is how the best fit sphere is calculated. And by excluding the center, we can even pronounce when calculating the best fit sphere, when not taking into account the center of the cornea, then we can even have a more pronounced elevation map in the center in keratoconus patients. So here we can see that there's quite a high elevation of the posterior surface of the cornea towards the anterior part of the cornea as an early sign for keratoconus. Well, this is a typical change. We see the bow tie and keratoconus and topography, and we of course can also have this calculation of a keratometry map with these modern tomography devices, and this resulted in the Björn-Ambrosio enhanced ectasia display, where we can have different indices, which can also be combined indices displayed here at the bottom of the display, indicating that there is keratoconus. And here we can see the elevation map of the posterior surface of the anterior surface, which are also displayed in these indices here at the bottom. The thickness of the cornea is displayed here. So we see this is a thinner cornea, and you can see other indices here indicating that this is a keratoconus. So this is very helpful in daily clinical routine of the cornea, and this is well established. So, but we have also with these advanced imaging techniques, the possibility to use them in other diseases besides keratoconus. And we have a special interest in Fuchs initial corneal dystrophy. And in Fuchs initial corneal dystrophy, we have also changes of the shape of the cornea. The first thing to know is that the individual normal thickness of a cornea in a patient who has Fuchs initial corneal dystrophy is unknown. So if you see a cornea and the patient has some complaints, but the thickness is still 580 microns or 590 microns, so you don't know whether this is already a swollen cornea or not, if it's not obviously opaque by the edema of the cornea. So the change we typically see in the shape of the cornea is also more located in the at the posterior surface of the cornea than at the anterior surface. So here you see not too much change of the posterior surface, but when the edema progresses, then we have more and more depression of the posterior surface. So it's the opposite of elevation, it's depression. And this also leads to a change in the overall curvature of the cornea. So typically a cornea has a prolate posterior surface, but if we have a depression here, then this will, if it's very pronounced, this will become an oblate form of the posterior surface. And the problem is that if we perform a DMAC surgery in this patient, is that the corneas in many of those patients will become abnormal thin. So we have quite a few patients who have a thickness of the cornea after DMAC surgery, which is very close to 500 micrometers or even below. And in those patients, there is a change of the ratio of the posterior corneal curvature to the anterior corneal curvature. And this is important because our standard IOL formulas usually depend on a strict relation between the anterior corneal curvature and the posterior corneal curvature. But if this relation changes, this also will change the results of our IOL calculation. So this needs to be taken into account, and it's well taken that after DMAC surgery, if this is combined with cataract surgery, for example, then we need to consider a hyperopic shift in many of our patients. And we know if this edema in the center is more pronounced before the surgery, then the risk of having a hyperopic shift is even higher. So it's a standard rule. There's this 1 diopter up rule of IOL power, or you just simply can aim for your aiming refraction minus 0.6 diopters. So that's a general rule, but this is not individualized. So we know that the cornea has a prolate form, which is good because we know that spherical forms have what is called the spherical aberrations. though the light beams going through the periphery of a spherical cornea would meet a little bit before the focus of those light beams, which go more to the central part of the cornea. And this spherical aberration is present in spherical forms, optical forms, but the cornea has a prolate form where the beams from the periphery are less focused to the center, and so the focus in a cornea is of higher quality. But in an oblate form, it's the opposite. Here we have a change of the curvature of the cornea, where the cornea becomes steeper towards the periphery, and here it becomes flatter towards the periphery. So the asphericity of the posterior surface in Fuchs initial corneal dystrophy is often less prolate, or it's even oblate before a DMAC surgery. And after DMAC surgery, this will result in an abnormal posterior to anterior corneal curvature radii ratio. And we know that the less prolate or the more oblate a cornea is before a surgery for a triple DMAC, the more hyperopic shift we will have after triple DMAC. And if you look on our display of our tomography device, some of those devices offer what is called the Q value. And here we know that positive values in this area, it's displayed, these positive values, they stand for an oblate form, and negative values stand for a prolate form. And if the value is around 0.2 or 2.5 or 0.25, this is considered a normal prolate posterior surface of the cornea. So why is this important? As I said, Fuchs initial corneal dystrophy and cataracts are quite often present in the same patient, because both are diseases of the aging population. And we can perform the surgery combined quite well, because we have almost the same entrance wounds for DMAC surgery and also for cataract surgery. And there are some pros and cons to combine the surgery or not to combine the surgery, and it always depends on the state of the disease. So if we combine the surgery, the positive thing is that the phacoemulsification is performed before transplantation, which means that phacoemulsification won't affect the graft. But the disadvantage is that we have these inaccuracies of the IOL calculation. There's also variable pupil constriction during the DMAC surgery. In sequential surgeries, we could first do the DMAC and then do the cataract surgery, or first do the cataract surgery and then do the DMAC surgery. And this depends on the stage or the grade of the diseases. So if we have only little changes in the cornea and the corneal endothelium, it could be advisable first to do the cataract surgery and then see whether the DMAC surgery is even necessary. But what we want to avoid is that there is a decompensation after cataract surgery in patients where we only perform the cataract surgery and don't do the DMAC surgery. And even if the cornea is of more or less normal thickness, still we could see some changes in some of those patients, indicating something which is called a subclinical edema in Fuchs initial corneal dystrophy. And to see these changes, we need to see the pachymetrical maps displayed here on the right side. These are two maps from a patient with subclinical edema. At the top, it's the pachymetry map, and here we have an elevation map of the posterior surface. And the first indicators of a subclinical edema is the loss of regular isopaths. And this means that we have these colored lines indicating areas of the same thickness. And usually, if you see here this patient after DMAC surgery, you can see that there's a very even circular or oval distribution of these lines. In contrast, here on the left side, also this cornea has a normal corneal thickness. We see a change in the distribution of these isopaths. So this is one of the first signs. The other sign is the displacement of the thinnest point. And the thinnest point is here located at the top of the elevation map. And So the thinnest point, here we have it on both maps, the parimetry map and the elevation map again. And here the thinnest point is in the inferior temporal quadrant, which is normal around 1 millimeter or within 1 millimeter to the pupil center. But here it's completely dislocated. It's outside the inferior temporal quadrant, and it's more away than 1 millimeter from the pupil center. So this is another sign, the second sign for subclinical edema and Fuchs initial corneal dystrophy. And the last sign is the focal posterior depression. So there is a depression which is displayed by negative numbers as seen here, which means that there's a depression of the posterior surface towards the inner direction of the eye. And if this is seen within a central 4 millimeter area of the cornea, then this is what we call the focal posterior depression sign, indicating subclinical edema Fuchs initial corneal dystrophy. And again, here on the right side, you see after DMAC surgery, we only have elevations in contrast to depressions in the central area, indicating that there's no edema anymore present. And we know the more of these signs are present, the higher is the risk for decompensation after cataract surgery in the Fuchs patients. So having these signs in mind, it helps to counsel the patient for cataract surgery if they have Fuchs initial corneal dystrophy. So after this first part, I want to ask the first question where you can call. And the first question is, which statement in the context of Fuchs initial corneal dystrophy is wrong? First answer is progressed Fuchs initial corneal dystrophy comes with posterior depression wrong? Is the healthy posterior corneal shape is prolate wrong? In a healthy cornea, the thinnest point is located in the upper nasal quadrant. Is this wrong? In a subclinical edema, the corneal thickness is within the normal range. Is this wrong? Or is the posterior corneal surface in Fuchs initial corneal dystrophy can be oblate? Is this wrong? So yes, so you have decided. So most of you have decided for in a healthy cornea, the thinnest point is located in the upper nasal quadrant, which is correct because it's in the inferior temporal quadrant. So this is the correct answer. Here it is. Okay. So we have new treatment opportunities for our Fuchs patients. So we treat them typically with endothelial transplantation, either with a DMAC or with a DSEC graft. And if you looked at our patients, we quite frequently saw kind of geographical changes at the level of Descemet's membrane and corneal endothelial cells. And this has not been, although it is very obvious if you look at your patients, you will see it in many of those patients, but this has not really well been described so far. And a colleague of mine, Professor Mario Matti, a former colleague, he started to gather all the samples from our patients and analyze them microscopically and check for these changes especially. And he realized that this is a really type of membrane, which he calls a fibrillar layer, which is present not in all patients, but in many of the Fuchs initial corneal dystrophy patients. And it describes a central subendothelial collagenous deposit. So it's between the corneal endothelium and the Descemet's membrane. It has a more or less clear geographic pattern, and it marks areas where endothelial cells are less dense. So you have a loss of endothelial cells, especially in these areas. So he stained this for different types of collagen and showed that these collagens are present in this fibrillar layer. So why is this important for our patients? Because we just remove this area and then do a DMAC or DSEC surgery. But there are new treatment options or newer treatment options. They compromise just the removement. They comprise just the removement of the diseased central parts of the Descemet's membrane and don't do a grafting of allogenic material. Of course, this would be of benefit because there cannot be any rejections in those patients. And we know from some years already that corneal endothelial cells, even if they do not proliferate well, or even if they do not proliferate, they can migrate to areas where endothelial cells are missing. And the first idea that one could just remove the diseased area and then just wait was already described more than or almost 50 years or more than 50 years ago. And then the first case reports came out around 2012 by Rupa Shah, where she reported just a removal of this transmembrane, which was successful in the central area of the cornea. And there was another colleague from Rotterdam who made a case series of 10 patients. Unfortunately, he did not really publish this case series, just reported on congresses. And he was very disappointed. He removed quite a huge diameter of diseased corneal endothelium in these patients. And most of those patients really needed an allogenic graft to have a cornea cleared up. But we now know that there is a limitation in doing this procedure. Only patients where the very central part of the cornea is affected by Fuchs endothelial corneal dystrophy, and it's limited to a 4 millimeter diameter, only those patients can be treated with this approach. So only in patients where 4 millimeter are affected, these 4 millimeter can be removed. And then you see here an example from our department on the right side. First day, very swollen cornea. The thickness is more than 1,000 micrometers. And then already after 3 weeks, we see the cornea is much clearer already. And at our last visit, this patient had a vision of 20/20 already. So what does fibrillar layer might have to do with this? So you could fancy that if you have a fibrillar layer, we know that the fibrillar layer is has less endothelial cells, then it's advisable not to include patients where the fibrillar layer is located also outside this 4 millimeter diameter. And it's not very easy always to visualize the fibrillar layer at the slit lamp. So what we have with our tomographic devices is also the corneal densitometry, which is basically the backscatter image this device gets from the cornea. And there was a very interesting finding that if you adjust the level of the plane of the backscatter to the plane of the fibrillar layer in backscatter, you can be able to visualize these geographic fibrillar layer just by the backscatter image. And this again was work performed by my former colleague, Mario Mattei, where he compared the backscatter of patients who did not have any fibrillar layer at slit lamp with those with fibrillar layer visible at slit lamp. And he also correlated this with the histology of those patients. So this is quite a useful tool if you have patients with fibrillar layer, want to perform a DSO just to have a good impression about the actual size of the fibrillar layer. The next section of my topic will be about corneal morphology by OCT images. And OCT originally comes from the retina and from choroid imaging, and then it took some years until we also had the first OCT for anterior segment imaging. So the first generation was slit lamp OCT, which is quite nice. We had this until some years ago still in our clinical routine because it gives a very good overview. The resolution is low, but it was high enough to example, identify DMAC grafts, which we do quite often in our department. But the acquisition time is very slow. So you can really see the beam going from left to right while taking the tomographical OCT picture. Then the second generation is based on SD OCT, which is used for the retina again, and then in combination, at least the device we have, combination with a special lens, this can also be used for the cornea. Here, the overview is much smaller than the slit lamp OCT picture. It has a much better resolution. It's much faster than the previous version, but still it's not fast enough to have a good number of stacks which can be used to calculate tomographical maps from the OCT images. This is the slit lamp based OCT, which we used for quite a while. You can see both sides of the limbus of the cornea. And as I said, it has a low resolution. and the slow acquisition time. No, more or less state-of-the-art still is the SD OCT of the cornea. The resolution is still very good, much faster than the previous one, but as you can see, we cannot see the limbus on both sides. It's good enough to visualize detachments after DMAC surgery, till the example as seen here in this picture. And DMAC is the main type of corneal transplantation we perform at our department. And we analyzed our DMAC surgeries for graft failure rate and graft rejection rate, and realized that graft rejection is very low, about 2% within 4 or 5 years. So graft rejection rate is very advantageous in DMAC compared to PK. And still we have this cohort of patients which are at a very high risk of graft rejection. And we call this high-risk initial keratoplasty patients. These are patients in which we perform DMAC for many years over and over again. These are patients, glaucoma patients, which had trabeculectomy or the implantation of glaucoma drainage device. And as you can see here in our cohort, the change of the curve over time, representing the graft survival rate after trabeculectomy, after glaucoma drainage device, it goes quite down. The direction is downwards. So we have an average graft survival time in these glaucoma drainage device patients of only 2 years. And we have patients who already had 3, 4, even 5 DMAC grafts showing up every half a year for a new DMAC graft. And why do we have this problem? So we have many indications with patients for BMAC, other indications than focus initial corneal dystrophy with the blood-aqueous barrier. The blood-aqueous barrier is very important to prevent graft rejection. This has been shown by other analysis papers which are out there already. And so we have different diseases listed here, which we, for these patients, we provide typically DMAC surgery. And they are associated with inflammation, and they are at a higher risk of graft rejection after DMAC surgery. And then there came out this quite new device. So this was introduced into market a little more than 1 year ago. And we started treating our patients with this device who are at a very high risk of graft rejection after regular DMAC surgery. So this device looks more or less like a contact lens. It's made of hydrophilic acrylic polymer. It's the same material as the material which is used for IOLs. The principle is completely different from human tissue, which is grafted from a DMAC graft or from a DSAC graft. So this device is also placed to the posterior surface of the cornea, but it seals the posterior corneal stroma and prevents the passive inflow of aqueous humor into the corneal stroma. This has been CE certified for the European market, so this is approved for the European market. And I think there are also other markets which will soon be, this device will soon be introduced. The diameter of the device is less than the diameter of the graft we use for transplantation. It's only 6.5 millimeters in diameter. It's dome-shaped. The thickness is 50 microns and the curvature is 6.8. This is how the transplantation is performed. Though first we remove the diseased endothelium. This is the same as we do this also in DMAC or DSAC surgery. However, the area which is covered by the device later on is only 6.5 millimeters. So we remove the diseased destinous membrane only in an area of 7 millimeters. And then it's very easy to introduce the device with a spattler into the anterior chamber. And the positive thing about this device is that it almost automatically unfolds itself. But the negative thing is that the adhesion of this device is much worse than the adhesion of a DMAC or DSAC graft. Especially if you have patients with defects in the iris lens diaphragm, then these patients quite frequently need rebubblings over time. And to avoid a complete dislocation of the graft, a fixation suture is placed, as you can see here, in this at this place here. This is a transcorneal fixation suture, and we also close all wounds with sutures to prevent any outflow of the gas which is supposed to stay in the anterior chamber to attach the graft. This is a clinical example. And again, imaging is very useful because by slit lamp examination, and this is in contrast to DMEC or DSEC, by slit lamp examination, you cannot really see whether this device is attached or not. You see sometimes additional reflections and think it's not attached, but then on OCT you can see that it's attached. And in this patient who had a lot of different surgeries before, including also penetrating graft, which then decompensated, and here this device was introduced and attached to the posterior surface, and then over time the cornea became thinner and thinner. And here at this examination, it was already only 433 micrometers thin. So the corneas tend in some patients to become even thinner than normal. And here you can see how this device looks on OCT images. So if it's attached, you will only see the posterior surface of the device. If it's detached, you can see the anterior and the posterior surface of this device. This is another example where the iris lens diaphragm was not intact, and here we needed several rebubblings to have this device attached, but at the end we succeeded, also with additional fixating sutures. And then one can see that the cornea becomes much thinner, back to normal levels over time. This is the results we published quite recently, where we analyzed our cohort of glaucoma patients at high risk for graft rejection after DMEC. Many of those patients had already DMECs before, and on average, the central corneal thickness was 795 micrometers. And then 3 to 4 months after surgery, when the grafts were attached, was around 500 micrometers already. So now we come to the point for the next poll question. And the question is, which statement in the context of posterior lamellar keratoplasty is wrong? So we asked for the wrong question again. Is it graft rejection rate after DMEC for Fuchs anterior corneal dystrophy is around 2% within 5 years? DMEC after glaucoma surgery has a high graft failure rate. All endothelial diseases can be indications for DMEC. EndoArt is a novel endothelial keratopathesis for endothelial decompensation. The EndoArt keratopathesis cannot be visualized by OCT. So the results are a bit diverse. So some of you think that all endothelial diseases can be indications for DMEC. I think at least, let's say, almost all can be indications for DMEC. But the correct answer, I think, is that the EndoArt keratopathesis cannot be visualized by OCT because it can very well be visualized by OCT. You see this double contour of the device on the OCT images. So the latest generation of OCT imaging is multimodal imaging based on swept source OCT. And swept source OCT is characterized by a long wavelength. So therefore, it has a deeper penetration into the tissue and also into the eye. It's a high-speed examination, and we have so many pictures we can get within a very short time that these pictures allow us to combine this picture to receive topo and tomographic changes on maps and combine them with the corneal morphology. Well, these are the 3 generations of OCT we had at our department: the slit lamp-based OCT, SD OCT, and swept source OCT. And as said, the penetration of these longer wavelengths of the swept source OCT allows us to go deeper into the eye and even to go through pigmented areas, at least in some areas. So you can also see here's the ciliary body in this swept source OCT image. And these images can be combined to display maps of the keratometry, of the curvature, of the thickness, and of the elevation, and even of the corneal epithelium. And your devices also allow us to produce difference maps comparing the right and the left eye in the corneal thickness. So here you can see a difference map where you see that the conus area here on the right eye is even more pronounced by this difference map of the corneal thickness. This was a keratoconus patient. So the swept source OCT is also very helpful in checking the fitting of contact lens. Another clinical example, though, this is the SD OCT, also already very helpful. This is a scleral lens. Unfortunately, I don't have a scleral lens example here on the swept source OCT, but as you can see, again, we see the limbus on both sides. So this is very helpful to check the good fitting of all different types of contact lenses on the cornea. And this is a clinical example of a patient after DMEC, where we found quite a decreased visual acuity, although the cornea looked very nice, it was clear, but there was an irregularity of the corneal surface. And with these new devices, we are able to place something quite similar to an ultrasound beam, which is called the B-scan. So you can direct the B-scan in a certain direction. And on this B-scan, you can place what they call an A-scan. And this A-scan allows you to correlate a certain area of the cornea, as seen here, with the change of this certain map. So here we choose the anterior axial curvature map, and we can correlate the morphology in this area directly to these changes in the curvature. So in this patient, we could not find anything which is very special here. The only thing is that the corneal thickness has a different pattern in this area here, which indicates that there is a slight decentration of the cornea, and which might be accountable for the refractive irregularity at the surface. And here, because this is soon after DMEC surgery, we just need to counsel the patient that he should just wait until the cornea becomes more even, but we could exclude that there are any morphological changes in the corneal stroma, which also could be accountable for this refractive change. So graft detachment after DMEC, our daily business, and in SLOCT, the resolution was much worse than the resolution we now have with the swept source OCT. Another example where this correlation of morphology and the refractive changes of the cornea are very useful are Salzmann nodules. These are hyaline material which is located on the Bowman's layer. So typically they can easily be removed. So when should we remove them? Of course, if the patient has problems, but it's always nice if you could correlate the problems, the symptoms of the patient with the changes in morphology and also in the refraction of the cornea. So here's an example. If you see the Salzmann nodule, you could think that there's still a difference to the center of the cornea. But if you look on the actual curvature map, the anterior curvature map, then you see that there's such a huge area which is much flatter than the rest of the cornea. And again, we can correlate this with our A-beam to that area where the Salzmann nodule is. And here we could really correlate well the changes in the curvature changes with the Salzmann nodule, which is responsible for this change in the refraction and the irregular shape of the astigmatism. This is a patient who had a stromal scar after inflammation. And here the question is, should we perform DALK or should we go for PK? And if we check the posterior axial curvature, we can already see these irregularities. And again, this can be correlated with the change of the posterior stroma, which shows here a depression of the posterior stroma. So just by simply removing the corneal stroma very close to the level of distance membrane, and one would need to leave some of the stromal scarred area here because the risk of having a tear in distance membrane is too high during preparation. But this will leave the irregularity of the posterior surface here, and therefore we decided to do a full thickness keratoplasty in this patient. Again, here it's the posterior elevation map correlating also with this area here where we have this depression indicated by the negative numbers here. So here is an image of a patient with congenital hereditary endothelial dystrophy, CHED. This is a disease where the children, when they come to world, already have opaque corneas. And the special thing about this image is that this was an infant. This was a small boy who was only of a few months of age, and still we were able to get this image without any anesthesia. And this is possible in many children, especially in infants, to get these images. You just need some patience, but after a while, it's possible to get these images, allowing you to get the right diagnosis without any further anesthesia in the patient. So before, we typically took the patient into anesthesia, made the diagnosis, and then the kid was awake again. We needed to order a cornea, and then we scheduled the patient for transplantation. Here you can directly go for transplantation in this patient, and this speeds up the whole process, which is important at this age to avoid further amblyopia in these patients. But not in all patients we are able to get the OCT images before, especially we cannot get from all areas of the cornea the OCT images, and then it's helpful to also have the OCT in the operation theater, and especially for children, we use this quite a lot. It helps us to image the corneal thickness during lamellar preparation in very opaque corneas. And it helps us to visualize also lamellar grafts, to the example of the DMEC scroll during DMEC surgery, the DSEC graft, and we can also visualize deep stromal alterations or anterior synechia, especially in phase of cloudy corneas. So the evolution of intraoperative OCT started with desktop machines, desktop devices, where the patient needed to, in anesthesia, needed to be placed in a certain way to make the to start the imaging process. And there came out also some handheld devices, and nowadays we have the OCT combined with our surgical microscope. And this is how it looks like if unfolding of a DMEC graft is performed under control with OCT, and the endothelial cells are always on the outside, though this scroll needs to open upwards. You see here the opening of the scroll, here one side and here the other. That's a very good sign. It looks almost like a pretzel. And then the orientation of the graft is correct. And here we can see how the inflation, here it's inflated by air, and then the graft is attached to the corneal stroma. Here the air bubble is a bit smaller, it's enlarged again, and then the graft is completely attached to the corneal stroma. And as said, it's also very helpful in the manual preparation down to the level of descemet membrane in opaque corneas. It's helpful to identify areas where still some fluid is in between descemet membrane and the stroma in a DALK patient during the surgery. And it's also good for control examinations. We did this quite often if we, when we did not have the more recent OCT swab source devices, we put the patient into anesthesia, and then we were able to see that the graft works, the cornea becomes less thick, and so this is something we need to perform less and less since we have the swab source devices. This is an example of a patient with Peters anomaly. You see anterior synechia of the iris, changes at the level of descemet membrane and corneal endothelium, opaque parts of the cornea, and here there was a correctopy of the pupil. The pupil was more decentered towards the 6 o'clock position, though this is during surgery. Here's the 12 o'clock position, 6 o'clock position. And the question was here whether we could improve the vision of the patient. This was a girl below 1 year of age by either a penetrating keratoplasty, but this patient, of course, has a very high risk of graft rejection. And then we decided, since the opening of the pupil was a bit descended downwards, we decided to do an autorotational keratoplasty instead of a high-risk keratoplasty. And here again, the IOCT was helpful to identify the areas where we have anterior synechia to avoid cutting through this and to reduce additional bleeding. So this is the third poll question. Which statement in the context of anterior segment OCT is wrong? So we look for the wrong answer again. SD OCT has better penetration through corneas than swept source OCT. Swept source OCT offers a good overview with high resolution. Multimodal OCT imaging allows correlation of morphology and shape. Due to its high speed, swept source OCT can also be used in infants. Intraoperative OCT supports posterior lamellar keratoplasty in opaque cornea. So we're looking for the wrong answer. Yeah, so most of you found the right answer. SD OCT has better penetration through corneas, so to corneal opacities than swept source OCT. That's the wrong answer. So swept source OCT, due to the longer wavelengths, has better penetration through opaque corneas. So the last slides, I just want to show you some clinical aspects of in vivo confocal microscopy. We use it mostly for the identification of acanthamoeba cysts in acanthamoeba keratitis or for fungal keratitis. The disadvantages, it strongly depends on examiner experience. So you need someone who really takes care of this over time, and best is only to have 2 or 3 people who know how this device works. It's a contact examination, especially those patients who have inflamed corneas or eyes. They feel quite uncomfortable with this examination. This is an example of a patient where we could see progress in corneal neovascularization and only this type of dirty epithelium, which is a sign for acanthamoeba, but we could not find any ring infiltration here. But by confocal microscopy, we could see this double-walled cysts here, which is indicated for acanthamoeba. And if you look here after Dalk in another patient, how this looks in the corneal stroma, the cysts are located almost everywhere from anterior to posterior. You can find them very deep in the corneal stroma. And by confocal microscopy, either this double-walled cysts or these bright spots seen here indicate this is acanthamoeba keratitis. So this is a very fast diagnosis, and this is important because it's very often misdiagnosed, and the differential diagnosis is often herpes keratitis, but this helps to really have a very fast diagnosis before having the culture or the PCR results. Another very important field of infectious keratitis where this is useful is fusarium or fungal keratitis. Here the example is fusarium keratitis. And not always by the clinical aspect we can say that this is a fungal keratitis. We need, in most patients, we need the histology or we need the cultivation results. And here we have live histology by demonstrating the micelle of the fungus. And here is an Aspergillus flavus keratitis, very dense micelle. And this is very important to have an early diagnosis of fungal keratitis. And in fungal keratitis, it's very important to start very early with the treatment. And my last clinical example for in vivo confocal microscopy is a patient demonstrated here who had pain in one eye. The other eye was a traumatic eye, but the healthy eye started to have pain. And if you look at the eye, at the slit lamp, it completely looked normal. There was a normal breakup time. There was normal tear film. There was a healthy, smooth surface of the cornea, no staining. And still the patient had pain. So we started to treat with lubricants, no improvement. But when we performed in vivo confocal microscopy, we could find some inflammatory cells in the subbasal nerve plexus. And then, of course, we started with anti-inflammatory treatment, steroid treatment, and then after a while, the pain was gone. And we could also correlate this with disappearance of these inflammatory cells in the subbasal nerve plexus. So I think this is another very interesting approach demonstrating inflammation in corneas, especially in patients with dry eye disease at different stages, to correlate this also with the success of the treatment of the disease. Well, this is the end of my presentation. And in summary, I would say that advanced imaging enables three-dimensional visualization and quantification of the corneal shape. Advanced imaging supports lamellar corneal surgery and the development of new surgical therapies. The significantly increased speed in image acquisition enables the examination of small children and infants without anesthesia. In vivo confocal microscopy allows immediate diagnosis of infectious keratitis. So I want to thank you for your attention. And now let's see whether there are questions from the audience. So one question here is, can EndoArt be used in corneal decompensation post-cataract surgery? Yes, so in principle, EndoArt can be used in all types of endothelial decompensation. Since this is quite a new device, we limit the use of the device currently to patients who are at a high risk for graft rejection after DMEK. So we don't do the implantation of the device yet in our regular Fuchs endothelial corneal dystrophy patients who are at a very low risk of graft rejection, because we have something which works very well, and the diameter of the device is less. And we know that if the diameter would be larger, from earlier results from the company who developed this device, that the cornea becomes thinner and thinner and thinner over time. So this probably has something to do with nutrition of the keratinocytes in the corneal stroma. And therefore, the diameter of the device is limited to 6.5 millimeters. And those patients, they will have edema peripheral to the device if you remove a larger area of the Descemet's membrane. So if it's only the central part affected by Fuchs endothelial corneal dystrophy, one could also think that just perform a Descemet stripping only. In bullous keratopathy, at a normal level of risk of graft rejection, we haven't performed that yet, but it's possible. So here the question is, would you recommend DMEK surgery for a patient who has been diagnosed with keratoconus and been previously fitted with scleral lenses but still has discomfort? Yes, so I think that's a reasonable approach. So if the patient was happy with the keratoconus before and is able to wear the contact lenses, then it's much faster to bring them back to normal vision if we perform DMEK in this situation. That's also the same approach we choose for patients who had PK. If the patient was happy with his PK graft before, then of course we don't do a re-PK, though in those patients we would do a DMEK instead of a PK. And then the patient will be happy with that too. So here's an interesting question regarding the future of in vivo confocal microscopy. Yeah, so I think the drawback of the device is that it's a contact examination, and you really need the people who are using this device, they really need to have experience and to be trained. So the examples I showed you, especially the infectious keratitis examples, I think they are the patient group which benefit most of this, because Acantha amoeba are not easy to show even by PCR or by culture. So this really gives additional information, and much faster information than the information we can get by the histology or by the microbiology. So I think in those patients, if you have this device, you should keep it and try to have it used in the clinical routine for such patients. Challenges in anterior segment examination in newborns. Yeah, so we have performed examinations in newborns at an age of 2 or 3 weeks already, which is very helpful because, of course, the patients are very anxious if they realize that the corneas are opaque. And one of my last patients, very opaque corneas, we did not perform anesthesia. We did perform the swept source OCT and could demonstrate that it's only the anterior part of the corneal stroma which was really deeply opaque, but only this was affected and the more posterior part was not affected. So we did not order a graft for this patient. We just performed the lamellar keratectomy, and the cornea looked very nice afterwards. Of course, no, the cornea has irregularities, but the chance of having some degree of vision is much better now. So it's possible also in newborns, and it's very helpful. So the next question here is, can EndoArt be used in penetrating traumatic corneas? Yes, so it can be. The problem is if you have irregularities in the posterior curvature and surface, then the graft has problems with alignment. So it could be that one needs more sutures, more fixating sutures, really to press the implant against those areas. And it could be that after a while, if you remove the sutures too early, that they can also, the implant can detach again. What you see over time is that by OCT images, that at the edge of the device, you will see a fibrotic reaction. And this fibrotic reaction, is quite indicative that the device is fixed well to the cornea, and then it's more or less safe to remove the sutures. Yes, I think this is most of the questions. And yes, I want to thank you for your very nice questions and the discussions after this presentation. And I hope that you got some new information of some of the aspects which quite often play a role at our department. Thank you.